we like to say that quality improvement is not rocket science. It's very practical, simple stuff. And it's common sense. And when you go to healthcare, which, by the way, didn't happen for a good 70 or 80 years after quality improvement was developed. It was around the late 80s, early 90s, where people started to think, well, why can't we apply these methods so that when people access health services, that we can have consistent outcomes as well, and we can continuously improve our systems to ensure that people get the best outcomes. I'm not talking necessarily about variation in biology. There are obviously going to be different biological considerations, but in terms of service delivery and making sure that people get the same services, then we do the right things at the right time. That's about quality in healthcare. So we apply those same principles. We identify where the problems are by looking at our data. We can also identify problems by talking to people and asking them about their experience and having them say to us, we weren't treated well. And I think for people who need to keep coming back to healthcare, like in HIV or in any other chronic condition, they need to come back. And so we need to make sure that our systems are welcoming for them, friendly, and provide good care at the same time. And so ideally, then we bring together our healthcare providers that work in the system together with our clients or patients who use the system, and we look at the processes together. We have to have a good measurement system in place in the healthcare setting and standardized measures so that we can evaluate our systems and the quality of our systems. When I started working in this field, and we would look at clinical outcomes, and people would go back and say, why are people not virologically suppressed? Why are they not accessing treatment? They would make a list of all the different reasons. And stigma was always on the list, right? But people would, we can't do anything about stigma, they would say. That was the response. And you're absolutely right. Over the past decade, or maybe even a little more, we have learned that we can do things about stigma, that it is actionable. In the world of quality improvement, the challenge was, how do we measure? I should say quantitative measurement, or delete that. So the challenge becomes, how do we quantify stigma in some way? So I was very fortunate to be at a conference where I heard Laura Nigley talk. Laura Nigley had developed an instrument to measure healthcare worker attitudes and beliefs, observed behaviors in the health system. And I thought to myself when I heard her present, we finally have a standardized set of measures that we can use to track over time to assess stigma within an organization. So we want to think about reducing stigma in different ways. There's clearly an interpersonal aspect between a provider and a patient. Quality improvement focuses on the organization. There's also the system. and the way in which the services are organized and they're delivered that can create stigma. And of course, the two come together within the organization. And I bring that up because the initial response to dealing with stigma was training. Now, training is important. Training sensitizes people. Training can change the way a person interacts with a patient or a client. But training doesn't necessarily change the way an organization functions and the way in which a person experiences an organization. So we need to look at stigma through the lens of an organization, and that's where quality improvement comes in so well, to apply that kind of systems thinking to the organization. And so in this network, which was initially supported through PEPFAR, and is now supported through the generosity of Gilead and ViiV, we thought of measurement in three ways. One was to look at the clinical performance data and disaggregate it by population. That, of course, depends on whether or not the clinic captures the data by population in the first place, which is a challenge, particularly around sexuality, gender, and behaviors. The second